Hello, welcome to Medical Vocation. In this video, I'll be discussing about hypoglycemia. We'll be going through what hypoglycemia is, what are the causes of hypoglycemia, its symptoms, potential investigations, and then how to manage mild to moderate and severe hypoglycemia. So firstly, what is hypoglycemia? Hypoglycemia is defined as a blood glucose level which is under 4 millimoles per litre. Depending on where you are in the world. Some places use milligrams per deciliter, and I've just done a quick conversion, and so it's under 72 milligrams per deciliter. Now, there are various acute precipitants to hypoglycemia. I've kind of categorized this into medications and non-medications. So in terms of medications, the most common one is insulin. As you may recall, insulin causes glucose to go inside the cell, and hence there's less glucose in the bloodstream, and hence you have low blood glucose levels and hypoglycemia. The other significant precipitant is a sulfonylurea, which is an oral hypoglycemic drug that people take for type 2 diabetes. Out of all the oral hypoglycemics, in fact, sulfonylureas are the only one really that we worry about in terms of its hypoglycemic side effects. Then there are drugs that usually cause hyperglycemia. And so if you think about it, if we withdraw these drugs abruptly, then the patients might actually end up with hypoglycemia. And the classic drug there is glucocorticoids. Other factors include things like the patient's fasting, they've engaged in excessive exercise, alcohol due to its gluconeogenesis suppression effects can also cause hypoglycemia, and then acute illnesses as well can rarely cause hypoglycemia. Now, the risk factors for hypoglycemia include having had previous episodes of hypoglycemia, having had diabetes for a long time, and this makes sense because diabetics, especially type 1 diabetics, require insulin, and so they're at risk of overdosing on insulin. Type 2 diabetics, only if they've reached kind of the end stage of their condition, require insulin, so they're the proportion of people with type 2 who have hypoglycemia is less than those with type 1 diabetes. People on insulin and sulfonylureas are at high risk because it directly causes hypoglycemia, being elderly, pregnant, having cognitive impairment, liver failure, malabsorption, so not being able to absorb sugar, having cortisol or growth hormone deficiency, having recent weight loss, for example, having had recent bariatric surgery as well, are all risk factors to hypoglycemia. And then there's this concept that's really important to know about, and that's hypoglycemic unawareness. So normally when individuals have very low blood glucose levels in their body, they will tend to manifest various symptoms, but for these individuals they tend to not be aware that they have low blood glucose levels, and so then they're at high risk of having really severe hypoglycemia. So the risk factors to having hypoglycemic unawareness include being on insulin for a really long time, having repeated mild episodes of hypoglycemia such that they're almost kind of desensitized to it, and then being on certain medications that kind of suppress the symptoms of hypoglycemia, in particular your beta blockers and SSRIs. Alright, so what are the symptoms of hypoglycemia? So they can be categorized into adrenergic symptoms and neuroglycopenic symptoms. So adrenergic symptoms are really like your autonomic, sympathetic symptoms. So things like having palpitations, sweating, being tremulous, having nausea, vomiting, and being anxious. Whereas your neuroglycopenic symptoms include things like being quite hungry, finding it difficult to concentrate, being confused, in its severe state, the person can have seizures and be comatose and have focal neurological signs. And then just revisiting the concept of hypoglycemic unawareness. So these are people who don't often manifest with autonomic symptoms. So they don't really have nausea, vomiting. They don't really have heart palpitations. And so they often present straight away with altered mental status or maybe a coma, which can be quite devastating. In terms of investigation, so the go-to, very easy to do by the bedside, is your finger prick glucose test, and that'll give you your answer straight away. And just as an aside, just out of interest, there are some investigations that can be done when the cause of hypoglycemia is thought to be perhaps a little bit more sinister, or if you think that something more unusual is going on. You can also test like the patient's blood insulin level and their C-peptide level. If their hypoglycemia is due to insulin, then you'd expect insulin levels to be high. However, if they have a tumour that secretes insulin, like an insulinoma, then their insulin levels and their C-peptide levels will both be high. And likewise, if they have overdosed in sulfonylureas, then their insulin level and their C-peptide level will also be high. Alright, so in terms of managing hypoglycemia, it really depends on if the patient has mild to moderate hypoglycemia or if they have severe hypoglycemia. And the way in which we categorize patients into these two categories usually depends on how they are cognitively. So if they are confused, they have altered mental status, they have a seizure, they're in a coma, that screams, severe hypoglycemia. But if they're otherwise well, they're alert, their cognition's intact, then they're said to have mild to moderate hypoglycemia. If the patient's able to eat, for example, they're not fasting for surgery or anything like that, then we can offer them carbohydrates which are fast acting. And these are things like jelly beans, fruit juice, honey, and these should get the patient's blood glucose to go up quite quickly. Of course, if the patient is currently on an insulin infusion with dextrose, then we would also cease the insulin and we would continue the dextrose. Alright, so after 15 minutes, we would recheck the patient's blood glucose level, and if it's still under 4 millimoles per litre, we would have to repeat giving them that really fast, short-acting carbohydrate load, which is usually 15 grams. If they've taken a turn, however, and their blood glucose level is actually back to normal, we can step them to a longer acting carbohydrate. So these include things like sandwiches, a piece of fruit, milk, and so forth. So as we were mentioning before, the signs of severe hypoglycemia include things like the patient being really drowsy, being unconscious, having an altered mental status. And how we would manage these patients initially is that we would position them on their side, help to maintain their airways, calling a code blue, and then if they happen to be on an insulin dextrose infusion, it's important to cease the insulin straight away and to continue on with the glucose infusion. Now, there are two main approaches to treating these patients, and it depends on if they have IV access. So if they do, we can give glucose through their IV access, and this can either be like a slow IV push or it can be an IV infusion. However, if they don't have access, then we can give something called glucagon, and we give 1 milligram of glucagon as an injection. That can be through muscle, intramuscularly, or subcutaneously through fat. Again, we would recheck their blood glucose level, and if it's still under 4, we would repeat the same approach. If it is over 4 and their blood glucose has normalized, then it's time that we follow up with appropriate oral and IV treatment. So especially for patients who are treated with glucagon in the initial stage, it's important that we actually keep treating them, and that's through either a carbohydrate load orally or through IV treatment. So they can't just receive glucagon alone. And so that really concludes our little presentation on hypoglycemia. Thank you so much for tuning in, and we encourage you to go out and spread your own little light bulb moments in medicine. Thank you.